Imagine creating millions of smiles. Imagine helping people look good, feel good, and enjoy life. Imagine making people's lives better every second of the day. Imagine inspiring thousands of talented professionals worldwide who serve more than 200,000 customers in over 100 countries. Imagine pioneering, empowering, and partnering with dental healthcare providers worldwide. That's what we do every day. This is what drives us and fills us with passion. Driving breakthroughs and exploring new ground for more than 60 years. Our roots are recognized as a leading innovation and quality brand in dentistry. Innovation that's backed by scientific evidence, legendary Swiss engineering, and precision. We want to push the boundaries to enable the next generation of dental care. Welcome to the Straumann Group. With our brands and partners, we're even more committed to global dental care and excellence. Through innovation and excellence, we make better dental solutions available to more people to deliver more smiles. Education is the foundation of our success, together with the largest dental scientific network worldwide. We provide an inspiring working environment where talented people can excel, so we can realize our vision to be the partner of choice in aesthetic dentistry. More than creating smiles, restoring confidence. The Straumann Group, a powerful combination of great brands.
Muy buenos días a todos en México y en toda Latinoamérica. Mi nombre es Pablo Prado, soy vicepresidente de ventas para el grupo Straumann en Latinoamérica, y la verdad es que estamos muy contentos de estar hoy con todos ustedes en este fantástico evento de Bone and Tissue Days, organizado por el equipo de México. La verdad es que quería agradecerles a cada uno de ustedes que se han conectado a este congreso por disponibilizar el tiempo de sus clínicas. Sabemos que hoy en día el tiempo de sus clínicas es algo súper preciado en esta retomada, digamos, durante la pandemia, y valorizamos mucho el esfuerzo que están haciendo en conectarse a este evento. Estoy seguro que desde el punto de vista científico, del punto de vista de lo que son los speakers que tenemos en estos 3 días en este evento, será tiempo más que bien invertido, porque la verdad es que el nivel de speakers y el nivel también de participación ha superado claramente nuestras expectativas para este evento. La verdad es que si tengo que ponerme a pensar en estos meses, desde marzo para acá en Latinoamérica en general, y hablando específicamente de México, la verdad es que sabemos por las enormes dificultades que todos ustedes han estado pasando, con las clínicas cerradas, con el bajo flujo de pacientes en estos tiempos tan difíciles, y la verdad que llegar al 9 de noviembre y todavía seguir hablando del tema del corona es algo que quizás en marzo ni siquiera nos habíamos imaginado. Sin embargo, me parece que lo que es destacable y lo que es valorable en todos estos meses es que hemos hecho un esfuerzo muy grande por estar en contacto con ustedes, hemos hecho un esfuerzo muy grande por estar disponibles para ustedes durante todo este tiempo, y al mismo tiempo les queremos agradecer por esa apertura que ustedes han tenido con nosotros de conectarse a los distintos webinars que hemos organizado, de haber participado en las distintas jornadas de educación en las que hemos estado tratando de, durante el tiempo que las clínicas estuvieron cerradas o con menos pacientes, tratar de entregarles materiales de valor agregado y tratar de entregarles contenidos e informaciones que les iban a servir un día como hoy en el que ya vemos que las clínicas están en su mayoría abiertas, donde vemos que los pacientes han comenzado a regresar para hacer sus tratamientos, donde vemos que todos aquellos tratamientos que estaban pendientes antes de marzo, abril, hoy en día los pacientes están retomando con muchísima confianza porque ustedes les han dado confianza para que ellos vuelvan a sus clínicas. Entonces, la verdad que en ese sentido me parece que no es un trabajo que se pueda disociar. Estoy muy feliz del trabajo que hemos podido estar haciendo todos en conjunto, no solamente ustedes, digamos, en la punta, siendo, digamos, los que están de cara a los pacientes, sino también espero que ellos se hayan sentido bien acompañados por nosotros en todo lo que ha sido esta retomada paso a paso. Quería también hacer una pequeña mención, tanto Andreas Müller, que es nuestro country manager en México, como Guillermo Cuello, que es nuestro director de ventas para México, les hubiese gustado estar hoy acá. Por distintas circunstancias, ellos no pueden estar. Sin embargo, estoy haciendo esta introducción también en nombre de ellos y dándoles esta cordial bienvenida a todos ustedes en el Congreso. Quería agradecerle también, obviamente, al equipo de marketing de México, a Fabi, a Gaby, a Margarita, por haber organizado este fantástico evento. Creo que ya en este tiempo lo que nos hemos dado cuenta es que armar un evento presencial sabíamos que necesitaba de muchísima dedicación. Ahora, armar un evento digital creo que está a la par o a veces necesita todavía más preparación porque hay muchísimas cosas para tener en cuenta. Y dentro de las cosas que hay que tener en cuenta para poder armar un evento de este nivel es el tema de conectar profesionales que hoy van a ser los dictantes, a lo largo de estos 3 días van a ser los dictantes de este evento, que están en distintas partes del mundo. Y creo que eso también lo hace único al evento, porque dentro de lo que son los speakers que van a estar hoy y a lo largo de estos 2 días presentando para ustedes, tenemos al doctor Massimo Frosecchi. Estaba hablando con el doctor Massimo Frosecchi ahora minutos antes de hacer esta apertura para ustedes y estábamos interactuando y intercambiando un poco experiencias de cómo está la situación en Italia, cómo está la situación en Latinoamérica, y la verdad es que creo que si hay algo que es común en todos lados es que lo que hace la diferencia en cuanto a cómo lidiamos con toda esta situación básicamente es la actitud. Es la actitud, son las ganas de seguir adelante, son las ganas de seguir haciendo lo máximo posible, obviamente con todos los protocolos y con todas las limitaciones en el buen sentido que colocan las autoridades sanitarias en cada uno de los países, pero creo que la actitud mental, la actitud psicológica, la actitud de sentimiento de equipo son las que hacen la diferencia en estos momentos que han sido tan complicados y tan únicos, por decirlo de alguna manera, porque creo que nadie se imaginaba haber pasado por todo lo que hemos pasado en los últimos meses. También le quiero agradecer al doctor Alfonso Cayazo, también de Italia, que va a estar participando hoy de nuestro evento. I would like to thank both of you, Dr. Frosecchi and Dr. Cayazo, for being great speakers of these Bone and Tissue Days these days. I'm really happy to have you on board lecturing for our Latin American audience. So big regards to both of you. También agradecerle al doctor Huerta, que va a ser el speaker de México, que va a estar dictando en este evento, al doctor Kern de Brasil, un colega acá de nuestras tierras brasileñas, que es donde yo estoy basado en este momento en Curitiba, y también agradecerle a la doctora María Marta Fernández, una gran colega, amiga de Argentina, que va a estar hablando sobre todo el tema de recesiones periodontales. Excelente presentación, y un gran abrazo y una gran bienvenida también al doctor Signorio de Chile, que también nos va a estar presentando su vasta experiencia con botis en estos últimos, ya años, sí, varios años trabajando con botis en Chile. Todos dictantes y speakers de altísimo nivel. Me parece que cada minuto de esta conexión, estos 3 días, va a valer la pena. Tenemos más de 800 registrados para estos 3 días, con lo cual el nivel de audiencia, una vez más, nos muestra y nos deja tranquilos de que cuando hacemos el esfuerzo y ponemos un programa de calidad, no solamente en lo que son los speakers, sino también en los contenidos que ellos van a estar presentando, y como a mí me gusta decir, contenidos y materiales que ustedes al día siguiente en sus clínicas van a poder utilizar. Acá estamos hablando de la clínica diaria, estamos hablando de terapias que ustedes van a poder utilizar en sus clínicas prácticamente de forma inmediata, obviamente con los entrenamientos muchas veces que son necesarios, pero cosas que son realmente aplicables en su día a día. Y sin más, quería ir despidiéndome. Obviamente me voy a quedar conectado asistiendo a las presentaciones, pero me quería ir despidiendo y mandándole un gran cariño a todo el equipo mexicano. todo el pueblo mexicano que está hoy conectado aquí, los doctores, los profesionales y seguramente un montón de alumnos de universidades que están conectados hoy en este evento, porque la verdad que México en estos meses sabemos que no la han tenido fácil, al igual que los países de Latinoamérica, pero hoy la gran mayoría de los participantes son de México en este evento y sabemos que no ha sido fácil, pero queremos hacerles saber y que cuenten con nosotros y con todo el lead team de México, con todo el equipo comercial, de educación, de marketing, de back office de México, para resolver cualquier tema que ustedes tengan, porque claramente, y esta es una filosofía que nosotros hemos adoptado desde el primer día cuando todo esto comenzó, nadie de esto sale solo, de esto salimos todos juntos, y todos juntos es pacientes, ustedes doctores en las clínicas y nosotros desde el mundo corporativo empresarial apoyándolos y dándoles todas las herramientas que sean necesarias para poder apoyarlos como los hemos ayudado cuando los tiempos fueron fantásticos. Bueno, en este momento los tiempos no son tan fantásticos o estamos recuperándonos. El rol nuestro es estar cerca de ustedes para acompañarlos a salir de toda esta situación. Así que cuentan con nosotros, pueden entrar en contacto con cada uno de los miembros de nuestro equipo en México y saben que juntos vamos a dar vuelta a esta historia, como tantas otras veces lo hemos conseguido. Y ahora, para hacer el pase, digamos, y esto parece un estudio de televisión, para hacerle el pase al próximo presentador, quiero darle también una cordial bienvenida a Arturo Robertazzi, que es un gran colega y un gran amigo del equipo de Botis en Alemania. Arturo, si no me equivoco, está en Berlín en este momento, con lo cual, si se dan cuenta, hemos conectado Alemania, Italia, obviamente México, Brasil, Argentina y Chile, y obviamente los participantes de la gran mayoría de los países de Latinoamérica, entre los que seguro hay amigos colombianos, amigos peruanos, amigos argentinos y chilenos, obviamente, que tenemos speakers, y seguramente miembros de otros países donde también estamos activos y los productos Boti se comercializan también. Entonces, le paso ahora a Arturo, un muy fuerte abrazo para todos, espero que aprovechen muchísimo estos 3 días, porque la verdad que el programa científico es de altísimo nivel. Un gran abrazo para todos, espero que sigan bien, al igual que sus familias, y cuídense mucho y que las cosas sigan recuperándose. Un fuerte abrazo para todos. Chao, chao.
Sí, desde Berlín. Y gracias a Straumann para ayudarnos a organizar este evento increíble y naturalmente gracias a vosotros, a los participantes. Entonces, sí, yo me llamo Arturo Robertazzi, soy italiano, entonces lo que escucháis es un buen español. Lo que voy a hacer es moderar un poco el día y os voy a presentar un poquito y rápidamente qué es Botis, qué vamos a hacer hoy. Luego os presento el doctor Frosecchi y vamos a dejar el digital stage a Massimo. Cuando hablo de Botis, siempre digo eso porque es algo para mí muy importante. Botis es una empresa muy joven y jóvenes son las personas que trabajan en Botis. Somos más o menos todos científicos y estamos en Berlín, en Alemania. Y estaba diciendo, es una empresa muy joven. Botis ha sido fundada hace 10, 12 años y al principio había 3, 4 personas que trabajaban en Botis y el éxito de Botis. Es un éxito increíble en 10, 12 años. ¿Y cuál es el secreto? Bueno, es la calidad de los biomateriales y la variedad de los biomateriales. Como veis en esta imagen, casi cada año, desde el principio, Botis ha lanzado en el mercado un nuevo biomaterial. Hemos empezado con Straumann, luego la membrana Jason, Colprotect, la matriz Mucoderm y los otros biomateriales. Eso es el secreto del éxito de Botis. Aquí lo que veis son los biomateriales de una forma un poco más organizada en la rueda de Botis. Y una pregunta que siempre nos hacen cuando hablamos de los biomateriales de Botis es ¿por qué tenéis tantos biomateriales? ¿Por qué necesitamos esa variedad? Bueno, la idea que tenemos en Botis aquí en Berlín es muy sencilla. No hay el biomaterial perfecto, simplemente eso. No hay el biomaterial perfecto para todas las situaciones clínicas. Entonces, si eso es verdad, nosotros ofrecemos 3 tipos de huesos, Straumann de origen bovino, la línea Maxcraft de halogénico la línea de Max Resort sintético. Y el otro lado de la rueda, todo lo que se necesita para el tejido blando. Entonces, la membrana Jason, con un tiempo de degradación natural largo, 3-6 meses. La membrana que se llama Col Protect, que tiene indicaciones más para perio. La matriz Mucoderm, también una membrana sintética. Entonces, la idea es ofreceros a vosotros clínicos la posibilidad de elegir la combinación ideal de biomateriales para una situación clínica. Y eso hoy lo vamos a ver de una forma, digamos, práctica hacia el final de la presentación del doctor Frosecchi con el Body Solution. Lo que hemos hecho es pediros unos casos clínicos que el doctor Frosecchi hoy y mañana Caiazzo van a solucionar juntos con nosotros. Entonces, gracias a todos para enviarnos un montón de casos clínicos que nosotros hemos elegido para hoy y mañana para solucionarlo juntos. ¿Cuál es el objetivo de todo eso? Los biomateriales, los casos clínicos, vosotros que aprendéis a hacer eso, ¿cuál es el objetivo? Bueno, es el resultado funcional y estético optimal. Esa es la idea. Y lo vamos a ver hoy con Massimo Frosecchi, mañana con el doctor Caiazzo. Y en particular hoy lo que vamos a ver es, claro, cuando ponemos un implante necesitamos el hueso, la regeneración del hueso. Pero algo que nunca tendríamos que olvidar es el tejido blando. Y Massimo va a hacer exactamente eso. Nos va a enseñar una presentación fantástica con casos de regeneración, pero con una atención especial para el tejido blando. Esa es la idea, porque necesitamos el tejido blando para proteger nuestro implante. Algo muy importante, última cosita antes que empecemos, para los participantes que necesitan traducción, la charla del doctor Frosecchi va a ser en inglés y vamos a tener traducción en español. Por favor, para vosotros que lo necesitáis, hay la sala alterna donde hay una traducción simultánea. So I switch to English. I say hi to Massimo. Hi, Massimo, how are you? Connecting to Italy. We are trying to connect to Italy. In the meantime, that Massimo is connected, I'm going to introduce him. Massimo is, I would say, is an old friend. We met 5 or 6 years ago. I think Massimo was in Perugia, a small Italian city, where Massimo was giving an amazing presentation, and he showed a couple of cases with Mucoderm. And since then, so we started working together on basically 2 different levels. One clinical research level, and Massimo is doing a lot of research together with us, and on a more educational level to do events like this. So we traveled together Latin America, Europe. So I would say we became friends. So I will introduce you Massimo with a couple of words. Massimo has a private practice in Firenze, a beautiful city in Italy. And he works as a visiting professor at University of Genova, Italy. He's an ITI fellow and is also the director of the ITI Study Club in Florence. So he's going to talk about new possibilities in hard and soft tissue management around dental implants. So Massimo, thank you for being here, and the digital stage is yours.
Thank you very much, Arturo. It's a great pleasure. It's a great honor to be part of this fantastic meeting of Bone and Tissue Days in Mexico. I also thank Paulo Prado for the introduction. And we will spend a lot of time here making a long journey into the new possibilities in hard and soft tissue. And when we do this kind of webinars, this kind of online lectures, I think we must concentrate our attention in clinical possibilities, in clinical cases, because we don't have the same interaction that we have with participants on a stage. So we must try to speak especially in a clinical point of view. Just a little few words about my city. Probably some of you know the David of Michelangelo that is in our city. It's a 500,000 city with a population of 500,000 population. This is the cathedral that is still there after more than 700 years. I think at that time in Italy we were able to build the things in the right way, not like nowadays. And the city is very historical. It's a sort of museum. All the city is like a little museum, and you don't see face mask in this video because it's an old video, but now all the people is moving in the city with the face mask, unfortunately. This is the council building in the heart of the city. Probably some of you know about the Ponte Vecchio, the old bridge we will see soon. And a lot of tourists, not in this period, unfortunately, for our economy, but is a very historical and touristic place. Not just for Italians, but I think from all over the world people are coming. Probably many even from Latin American. We have, for example, plenty of Brazilians tourists. And it's a great pleasure for us to receive all these people from all over the world, and we hope to see you again soon. Okay, let's start our presentation. Nowadays, we have some implant treatment goals for posterior and anterior sides. Of course, we have to insert the implant in a 3D implant position, prosthetically driven, respecting the ideal position for the prosthesis. And nowadays, we take care a lot about the soft tissue, so the volume of the soft tissue, the keratinization, and of course, finally, a natural appearance of the restoration. For anterior sides, everything become a little more complex because we, of course, place the implant in the posteriorly driven position, but we have to take care much more about the frame of our tooth, that is the soft tissue. So the soft tissue level, the soft tissue shape, the soft tissue color, keratinization, and of course the best prosthesis that we can. And in both conditions, in healed side or in fresh socket side, we have to respect exactly the same principles. We have to respect the minimal quantity of bone that was exactly clear from ITI principles. We have to respect the distance between implant and between implant and natural teeth. We have mainly to respect a sufficient amount of bone in the buccal plate to prevent resorption, transparencies, lack of osseointegration, and finally, but not finally as importance, the correct depth of the implant. That is a very well established measure for tissue level and bone level implants. As we want to respect all these principles, theoretically is very easy to do, but in a clinical point of view, as we try to maintain the implant in the three-dimensional position for the prosthesis, especially for a screw-retained prosthesis, very often we have to graft. So grafting became very, very common in my practice, and every year I increase the grafting treatments. And as more critical as we do fresh socket implants, for example, where we have to modify the implant position and we have to leave some spaces for intentional grafting between the buccal plate and the implant. So grafting became dramatically important. I remember when I started to place implants in the half of the 90s, the main idea was looking for bone. Bone was our fixed idea, no? We wanted a lot of bone, good quality bone, long implants, wide implants. We were only concentrated in bone, but now we are more concentrated in the correct implant position, Sometimes we prefer to decrease the dimensions of the implants, even because we can use better surfaces, better materials, and we can use in some application narrow implants, short implants, but we don't want to make compromises with the prosthesis. And when we approach the grafting techniques, first of all, we have to establish the surgical goal. Secondary, we have to choose the correct biomaterial, or we can use the autologous bone. We have to select one of the best techniques for grafting, because we have many different techniques, but not all techniques are the same, and not all techniques are the same in my hands. Because I'm more experienced with some techniques, I feel more confident. With some techniques, I don't feel so confident with other techniques. It depends also on my skill, on my experience, but even I think in the well-established technique in time. And finally, like always, to take care about the soft tissue. As we want to establish a surgical goal, we want to drive our implant in the ideal prosthetic position. When we talk about bone harvesting, we want to choose the ideal material, the correct technique, and what about the soft tissue we will see later. Let's analyze one by one these basic points. Some people show me some x-rays and ask me, is there enough bone for an implant in this x-ray? And I think this is the wrong approach to implant dentistry. Probably it was correct in the half of the 90s, but nowadays the correct approach is there enough bone to ensure our project? So first of all, we have to establish our prosthetic goal. Let's see this case. We have this young patient, Patty, from Eastern Europe. She has a removable prosthesis, and when she takes out this prosthesis, the situation is not the best. She wants to move to a fixed restoration. We analyze with models and pictures. We can see that this removable picture is not so bad as a starting point. We can use as a sort of walks up. What we are doing now, we are not concentrating mainly in bone, but we take, for example, digital impression in the mouth of the patient, and we can make a digital impression of the removable prosthesis to match them together, because, as I said before, it can be a sort of walks up in this case. And after a CBCT, we match the digital impression of the mouth of the patient with a CBCT. After that, we can match the walks up or the removable prosthesis, and we obtain at that moment everything that we need, that is the amount of soft tissue, the amount of bone, and the ideal position for teeth. So what we do now is, from the database of the software Co-Diagnostics, we can try to select the diameter of the implant, the length of the implant, taking care about the bone, but not just on the bone. Let's, for example, see in this case, I go back just one moment. Yeah, okay. If you see in this image, I have not a sufficient amount of bone to place a 3.3 millimeter implant. So my temptation, if I don't have any project into the software, would be to follow the direction of bone, trying to keep my implant as more as possible into the bone. But the bone is not sufficient anyway, and what I prefer to do is to respect the prosthetic plan and graft into the bone, because I can do many things with bone, but I cannot do many things if my implant stay in the wrong position at the end. because prosthesis can solve only minimally the problem that you create with the implant. So we go on and we decide this position. We want to use rock solid implants, 3.3 for premolars, for lateral incisor. And you can see how simple it is to establish the surgical goal when you start with these softwares. So mainly, as we do such a sophisticated planning, it's a pity to waste this planning. We want to bring this planning into the surgery. So what we do very often nowadays to design a guide, a computer guide. I don't like very much to work closed flap. In this case, it was impossible because we wanted to graft intentionally. So we drilled the bone after elevating a flap. And in this moment, I don't have to look because I trust in guided surgery, especially when is on natural teeth. So we insert the 3.3 millimeter implants. And after implant positioning, of course, we have fenestrations. Yeah, we planned to have this fenestration. But we are not stressed because everything was planned and we want to graft and obtain at the end the ideal axis for the prosthesis. So we mobilize the flap before using biomaterials, and we can use some bovine bone, in this case mixed with autologous bone that was taken from the patient, to obtain the correct protection for the threads of the implant and the correct volume for the final aesthetic. We don't want to have concavities, we don't want to have transparencies, so we use bone graft with bovine that give us the opportunity of long-standing volume in the anterior area, and we will cover with a pericardium membrane that is ideal for these indications. We correct all the concavities. We want to prevent any problem of aesthetic and every hygienic problem. So after that, we can simply close the flap that was mobilized before the surgery. So after that, we have a plan. We have to look for the ideal materials for grafting. And the three basic rules when we talk about biomaterials is to look for vascularity, because we all know that blood contains all the factors to obtain some bone. To look for some induction, especially as more your treatment is challenging, as more you need induction in your grafting material. For example, if I have just to correct the volume, probably I don't need so much induction. But if I want to make a vertical augmentation, or if I have a very big defect, I have to look for some inductive factor. And we have to protect from mechanical factors. So even in this case, as more the case is challenging, as more we need a protection from mechanical stress on our grafting materials. And the treatment option factors depends on many factors: the geometry of the defect, the size of the defect, how the biomaterial work in terms of effectiveness, in terms of resorption. We have to control the infection risk. We have to establish if the defect is critical or non-critical, and if the area is aesthetic or not aesthetic. I will not talk about all this point, but just telling you, for example, what do we mean when we say critical or non-critical? A defect, we can call it critical when the implant will stay mainly in regenerated bone. So we don't need just a volume, we need vital bone, we need something that is able to receive an implant and to be attached to this implant. And all these factors are very important. Now we will just concentrate on biomaterials. And when we talk about biomaterials, some of them are what we call bone fillers, not autologous bone. And we have to consider the effectiveness of these biomaterials and the resorption of these biomaterials. What we know is that mainly the gold standard remain the autologous bone, that is the only one who can give you an induction. The biomaterials that you can buy are normally the sort of frame, a sort of volume space maintenance, where the bone will grow. And if we see some papers, for example, and you consider this paper who analyzed the new bone formation, you can see that autologous bone is the material who bring more new bone, around 41%, instead of other materials, like, for example, the bovine, that is the last one, that in this paper was BioOS, that only bring 24%, 25% of new bone formation. So if you just consider these kind of papers, you would exclude the bovine bone, because you would probably look only for autologous bone. And this is not completely correct, because you have to mix these results with these other results, where if you see how much bone stay after regeneration, and only 20% of autologous bone remains. So you obtain new bone formation, but you have some resorption. On the contrary, with bovine bone, you obtain not so much new bone formation, but you have a long-standing material that stay and keep the volume. So we don't have a good material or a bad material. We have some features, we have some characteristics, and we can use these characteristics to achieve the ideal results for every kind of defects. And it's not so difficult to achieve autologous bone. We can achieve, for example, from rotary drills, where if you go slowly, and especially if you don't use saline solution, you can obtain a sufficiently good quantity of bone to mix with other biomaterials, for example. Or we can, for example, obtain with a piezo surgery, we can obtain some bone chips. We do sometimes when we work on the sinus area. We can sometimes collect some bone chips to mix with the biomaterials. Or we can use with the scalpel, for example. This is very good in anterior region. In nasal spine, we can achieve a very good quantity and a good quality of autologous bone that we will mix and place on the threads of the implant, in this case covered by bovine bone in the most external area, like Danny Boozer teach to all the world to do, to make a first layer of autologous bone directly on the threads of the implant, and to cover with a sort of shield made with bovine bone. Or we can use scrapers that are very useful, especially in posterior mandible or some areas of the maxilla. But very often we don't have enough autologous bone, or we don't want just autologous bone because we want a more long-standing material. Sometimes we used to mix, and we can use, for example, cadaveral bone, or we can use bovine bone, or we can use synthetic materials. You will not see in my cases with human bone, because in Italy we are not allowed to use. So most of my cases are made with autologous or bovine or synthetic. But the big differences are between the synthetic material and the bovine bone, because the bovine bone is very difficult to resorb completely, and we prefer to use this biomaterial, especially when we want to obtain volume for a long time, a sort of shield. Sometimes I say to my students, a sort of stone. Yeah, this is not very elegant as a term, but it fixes in the mind of students what's the meaning of using a lot of bovine alone and not mixed, for example, with autologous. On the contrary, when we talk about synthetic, is normally a material who resorb naturally around 3-6 months and leave the space for new bone formation. So if you want just to have volume, probably is not the first choice. But if you trust in a sort of very favorable regeneration of bone, like small defects or with many walls all around of autologous bone, you can even use the synthetic that is good for all the religions and all the kind of human being, because you know that every kind of biomaterial has some limitation on the base of ethic or religion of people. And my personal decisional tree is to use autologous bone in all the indication, I could say. Only if I want buccal plate maintenance of volume, to use the autologous bone alone is a little limited. I use synthetic biomaterial, especially when it's easy to have bone healing. For example, just to make an example, the sinus augmentation is a very favorable kind of defect, because you have a 5 walls defect where you have all bone around, and you have just to have some time for a spontaneous regeneration. We can use for small defects and for horizontal defects, especially mixed with other biomaterials. The bovine bone is good for most of indication. Again, I prefer to use bovine mixed with autologous bone, or I can use even bovine alone when I just need volume. And what about the barriers? Barriers are very important in our grafting techniques. We have a wide demonstration in literature that barriers are important. Membranes are important for lateral augmentation. We have better results. We have better results even in cases of ridge preservation cases. We will talk later about that. And one of the factors that became...
Hi, Massimo.
See?
Can you hear me? We already have a couple of questions.
Okay.
The biomaterials you were talking about. So you were talking about Cerebon, the bovine, Maxasorb synthetic, and allograft in general. So there's a couple of questions. One is, generally speaking, if you mix the bovine bone with autologous, and if yes, when, and the percentage, does it affect the clinical outcome?
Yeah. Generally, as more the defect is challenging, as more the percentage has to be around 50% and 50%. For example, when you make a vertical augmentation in bone, that is probably the most challenging application. The recommendation of the authors, of all the clinician, is to be around 50 and 50%. As more you have less challenging defect, more predictable defect, like the horizontal augmentation in a non-critical defect, where the implant will stay not all in regenerated bone, I think we are not so strict in this percentage. I could probably follow the Boozer instruction to make a first layer of autologous bone just to cover the screws and an external layer of bovine.
Perfect. Thank you. And just commenting on this, what is the role then, the autologous bone, when we are using a bovine bone? Why do we mix it?
The main idea, the main principle is to have some induction, because as you use just bovine bone, you have the blood that is filling all the empty space between the particles. So basically, you can have regeneration even with just bovine bone. Bovine bone is a fantastic material, is I think the #1 biomaterial in dentistry. But when you use autologous bone, you have a sort of booster for your regeneration, because it releases a lot of growth factor, and there are many papers who demonstrate that the particles of autologous bone are like the new center for new bone formation. So autologous bone is inductive. Bovine bone is conductive.
Perfect. And since we are talking about mixing, you also mentioned the possibility of using autologous bone and bovine bone in a layer technique. What is then the advantage of using first autologous around the implant?
Because
bovine bone to protect it.
We do all that because we want a safe osseointegration of the implant, and probably to have an initial layer of autologous bone brings to a very natural osseointegration of the implant. So you have on the direct contact with the surface of the implant the highest level of induction. In the external side, you have the advantage to have more stable material like the bovine bone. So the double layer technique is very, very old and very predictable, and we all love it because we have both the advantages using this kind of 2 layers into the regeneration.
Massimo, we also have another question, this one regarding the synthetic biomaterials. Obviously, there's many in the market, so people have had slightly different experiences depending also on what they used. And in this particular case, the doctor said, I've used a synthetic bone in the past and it never reabsorbed. Is this the one that you're using different? Yeah. That's the remodel.
This is a very good question, because I used the wrong term to say synthetic, no? Like if synthetic, it means everything. And it was my fault, because there are many different things that are synthetic. For example, if you use hydroxylapatite, this never resorb. So it's okay, synthetic, it's good for all the religion, all the ethical problems, but it's never resorb. When I mean synthetic, especially using botiss, I mean a calcium phosphate with hydroxylapatite, who obtain a very good and natural resorption into the bone. So it's very important the kind of biomaterial when we talk about synthetic, because we have, for example, in the market, not just hydroxylapatite, but we have bioglass, we have just calcium phosphate, we have just hydroxylapatite, we have a lot of different things with different resorption. So I'm sorry, I have to talk about only this combination of calcium phosphate and hydroxyapatite. That is the Botis biomaterial that I mainly use.
Just to comment on that, and then for the moment there are no more questions. One crucial aspect of a synthetic biomaterial that the listeners can look for, apart from the brand, so generally speaking, is the way that the particle, the microparticle looks like. The one that Massimo showed really looks like human bone, and this is the secret. It looks like human bone, and then it tends to behave like human bone. Like if you see, the one on the right, he has a very similar resemblance to human bone, and this gives a behavior that is like human bone. So this was the comment. So Massimo, for the moment, there are no further questions, so please continue. Thank you very much.
Okay, thank you, Arturo. I go now back to the slide when we talk about barriers. And let's see, for example, one case of my office. The patient came with this situation, 3 old implants, placed many years ago, but you can see the situation now with infection, fractures, and we have even a natural tooth that was compromised by that implant that is in the same position of the root, so everything was moving. And of course, I decided to take out all the implants and the natural tooth, and I didn't feel comfortable to place immediately implants in this situation, even because there was very irregular defects into the bone, and the situation of the soft tissue was not ideal for placing immediately the implants. So in these cases, I try first to take care about the hard tissue. So I used bovine bone in this case because I wanted to have a stability of the bone in this region, and cover everything with a pericardium membrane that is very stable for 3-6 months, so we can keep the volume. And as I want to be more sure about the position, about the stability of the membrane, I do very often this stabilization with titanium pins. That looks a little more difficult, but in reality, it's easier to manipulate these biomaterials, this membrane, using, for example, just 2 pins. We don't need 10 pins. We need sometimes only 2 pins to have the stability of a membrane. We can reflect the membrane on the lingual side without using other pins on the lingual side, because it will be sufficiently stable under the periosteal tissue, because it's not possible to move the membrane in the vestibular side. This was the primary closure that is mandatory in all our treatments. Every kind of technique you will use, you have to look for a primary closure. This is the healing at 6 months. That is the minimum time that we wait for bone regeneration. At the moment of uncovering, I placed 2 implants, and I wanted to obtain more volume for the soft tissue. So you see 2 slices of porcine dermis matrix who bring more protection and more volume for the soft tissue. And in this case, you can see the primary closure is not mandatory, because we can protect with the dermis matrix that is very resistant to hydrolysis into the mouth of the patient. We try to not to expose too much this biomaterial, but if we expose like 1 millimeter or even a little more, we have not big problems. You will see the healing and then the prosthetic final workflow with zirconia bridge. And the difference is you can see the stability of bone. We had some vertical component in the defect, and in these cases, I prefer to use bovine to prevent resorption of that vertical component of the defect. When we have to select the grafting technique, I suggest to you this very, very simple classification that we find in ITI treatment guide. It's not one of the most common classification, but in my opinion, it's very easy to remember and very, very easy to do. We divide in 4 parts the alveolar bone, and we can have the type when we lose 1/4 or 2/4 or 3/4 or just a
Massimo, sorry to interrupt you. There's a question regarding the previous clinical case. There's a delay of 30 seconds. That's why I interrupted you. Regarding the previous case, they were asking if they can leave mucoderm exposed again, and if yes, how would you decide the amount of mucoderm exposed?
This is one of the most difficult questions to answer. I will talk very much about mucoderm later. So just to spend 2 words, but we will treat more widely this issue later. I can say that I try to expose much as possible this biomaterial because the resorption is very unpredictable. If you ask me, there's a risk of infection, I say no. I use a lot of mucoderm, and infection is not a very common risk for this material. I would say it's very difficult to get infected, but you have a non-predictable resorption of the material. So this is the reason why I try not to expose very much this biomaterial. But if I have like 5 millimeters under the flap and 1 millimeter exposed, in my opinion, this is quite predictable as a good application. I can say the percentage could be like 1 to 3, 1 millimeter exposed and 3 millimeters below. But this is only a clinical point of view, is not something that with evidence-based, only clinically based. But I would spend more words about mucoderm later if we arrive at that part of the presentation.
Thank you, Massimo.
Thank you, Arturo. And this classification is for single tooth gap or for extended edentulous space or for completely edentulous jaw. And every possibility, like in all ITI publication that ITI, you all know, is fantastic idea to keep simple all the things, to be clear for clinicians, not to make tricks. And we have, for example, for single tooth, all the preferred technique or alternative techniques. For edentulous spaces, the same. Let's see some clinical example. For single missing teeth, when we have just the most crestal part that is missing, so the ideal situation for regeneration, or one of the easiest cases for regeneration, the preferred technique is GBR and implant placement in a single intervention. And we have an alternative technique that is to stage the GBR and not to do together with the implant. And how would you choose one or the other one of these techniques? We will see, for example, when we work in anterior cases and when the case is more demanding for aesthetics, sometimes we prefer to stage because we don't want to have a minimum risk of failure. So you have a double choice for these techniques, and we can choose if we feel if we feel confident with our experience, with our skill, with the kind of patient, with the kind of site, non-aesthetic area, to do all in one session, we can do it. But in some other cases, probably we are not so experienced, or we don't trust so much on this patient, or the patient is very demanding. We prefer not to look for a miracle, too many miracles at the same time. We prefer to gain bone and then to place the implant in the ideal situation, or even to correct an initial failure at the moment of implant insertion. Let's see, for example, we are not in anterior region. We have just a small defect. You can see I like very much tissue level implants in posterior area. And what I want to obtain is just volume. I'm not stressed about osseointegration of this implant. I have more integration that I need, but I don't want to have this exposure of the surface of the implant. I don't want to have concavity. I don't like the quality of the soft tissue. So I can decide to do something very simple like bovine bone to obtain volume, and soft tissue grafting with porcine dermis matrix in the external side, and this kind of healing with a healing abutment. You can see in a very single way, I obtain a convexity, a big convexity instead of a concavity. You can see how we started and how we finished after the healing. It's very, very favorable for start the prosthesis. As my defect is more deep, but it's still just horizontal, I don't have a vertical part of the defect. The ITI treatment guide text tell me that staged is more safe. As more the case is difficult, as more better to stage. In alternative, we can make a simultaneous implant placement with a GBR. Let's see, for example, this case. This tooth is failing. I think nobody have doubts about that. And at the moment of reopening, you see that we have no bone at all. In the horizontal side, we have the height of bone, but we don't have a good thickness in bone. The patient is not very much interested in aesthetic. The situation, in my opinion, is quite predictable. So I want just to keep my implant inside the defect, prosthetically driven, but using not a wide implant, using a narrow implant like a 3.3 millimeter. I keep the implant inside the defect to minimize the risk of problems, and I graft with bovine bone. Again, I can use a resorbable membrane with 2 pins to be sure about the stability of these regeneration materials, not to have squeezing of the biomaterial around, not to have mobility of the membrane during the closure of the flap. In case of multiple teeth, not single teeth, as we have an initial defect like that one, again, we have the indication for staged, or we have the indication for simultaneous implant placement. We see, for example, this defect in the mandible. We do a CBCT, and we observe that we have the possibility to place implants prosthetically driven, just exposing a little part of the implant, not very much. So the day of the surgery, I elevate a full thickness flap. Of course, we place 2 3.3 millimeter implants, and we have the possibility to make some holes into the bone to have more vascularity. And in this case, I wanted also to improve the...
Massimo, sorry.
Yeah?
We have another couple of questions. Again, referring to the previous slides. So you were referring to 1 2-stage surgeries approaches, and one of the questions is referring to, let's say, when you would do in an immediate implant placement, when would you do the soft tissue management? In which moment? At the beginning?
No.
Or at the end? And then, sorry, to add to this question, what do you do with the helium cap and the connection? Is this a problem to use a matrix or autologous tissue? How do you do it?
Which case? This one?
It was the previous one, I think.
This one?
Yeah, I think it was this one. Yeah.
Yeah, I like very much to use heel abutment. Every time I have a good stability for the implant and I have no removable prosthesis, I prefer to guide immediately the soft tissue in position, even because if I submerge this implant, I have to wait around 6 months because I placed biomaterials. As my biomaterial remain untouched later, I can just wait 2 months for osseointegration and I can start to do the prosthesis because my biomaterials stay untouched. I don't expose again the biomaterials. Every time I use biomaterials, if I have to uncover, I have to wait a longer time, because I don't want to disturb the regeneration process. I don't want to disturb the soft tissue that is healing. So it takes a long time, around 6 months. Sometimes it's good even to wait, but if I can wait less, I prefer to wait less for my patient. So when I have all my implants inside, I have no risk, no other kind of risk. I prefer to use a healing abutment. In this other case, for example, I don't feel free to use a healing abutment because my regeneration is quite critical. So I need to wait 6 months. So as I need to wait 6 months, has no sense to risk with a healing abutment. It's better to cover everything to obtain a good regeneration, a good stability, do not disturb the process, and uncover after 6 months. The case is not yet finished, but this was just to show the technique.
Thank you, Massimo.
Thank you. So in this case that we were seeing, I want to take care about the bone and I want to take care about the soft tissue. And you can see I used the dermis matrix as a membrane with 2 titanium pins. I know that this technique is not yet completely evidence-based, but as you know, this matrix, it stay around 6 months. So I feel free to use as a membrane, even if it's not properly a membrane. What I like of this technique is the shape that I obtain with using this material, because I have a very big elastic memory of the biomaterial. So you see how stiff is the biomaterial at the beginning. I have to bend it and fix with the pin, and you see one angle of the matrix that is coming out, and I can fix with a second pin and obtain this rounded shape that is, in my opinion, is very favorable. And the question you did before about when I take care about the soft tissue, normally I take care about the soft tissue at the moment of uncovering. So if I decide to uncover the implant, the moment for soft tissue grafting is at the moment of uncovering for me. And you can see I took, for other reason, a CBCT after 6 months, and you can see how the shape, the rounded shape of mucoderm gave me this fantastic rounded shape of the bone. So normally I say that the membrane take the shape of the biomaterial. When you use mucoderm, is the biomaterial who assume the shape of the membrane. This is something that I like quite a lot. At the moment of uncovering, I use connective tissue graft from the pellet. This was the situation at the moment of uncovering. You see the quality of the soft tissue is not good, because when you use mucoderm, you don't have to look for keratinization. Mucoderm is one of my favorite biomaterials, probably my favorite biomaterial, but I cannot ask this biomaterial to be inductive for keratinization. I want to obtain volume with this biomaterial. I want to obtain protection, but as I want keratinization, I need something from the pellet or from the tuberosity of the patient. So you see how using all these devices with two interventions, we achieve at the end a sufficient amount of hard tissue and soft tissue for two retained crowns. And this is after 3 years, the control.
Massimo.
Yeah.
Regarding this case, we have two questions.
I think we have to select a little, because we have many slides. I don't know if we have many slides. I don't know if we want to stay until tomorrow morning. We have to select.
Okay, we can select a little bit less.
Let's try to we can probably even select one or the most important question that you consider, or I don't know. Sorry.
All right. No. I mean, we will select a little bit more. I will ask you this too, and then we'll continue. So regarding the case with
the others for later. If we have time, we will answer to all the questions.
All right. Let's do that. So shall I ask you this too, or shall we?
Yeah, of course.
All right. So regarding the case with mucoderm and the pins, there were basically two questions. How long will you hydrate mucoderm to achieve that flexibility that is clear in the pictures? And if you use mucoderm in a situation like this, do I need to use a membrane? In other words, does mucoderm have a barrier effect?
No, I think mucoderm is enough as a barrier. If you use, for example, a JSON membrane and the mucoderm on top, probably it can be a little risky for the vascularization of all these materials, all these barriers. I think in this case, we could use JSON membrane, for example, excluding mucoderm, or we can use mucoderm. This case I like because it show you the opportunity to guide with this barrier the shape of the biomaterial. And as you know, Arturo, is a technique that I do very often, because in my experience, this biomaterial is a fantastic membrane. I know that it's a bit out of the indications, even if it's published, this application of mucoderm, but I think that we have a lot of advantages. Another advantage using this device is that if I have a little exposure of the flap, little reopening, just a little of the flap, it's less risky. Anyway, the time of rehydratation is around 20 minutes, 15 minutes, but I did many cases just using 3, 4, 5 minutes. So the ideal condition is around 15, 20 minutes, but it's not mandatory to wait so much. We can even start a little before.
Thank you, Massimo.
Thank you. So we proceed with this case that was already finished. We have the controlling time as we started and as we finished with a very simple technique. What is more demanding is when you have a more critical defect, like in this case I will show you, is the same patient that she received a kick from a horse when she was a very young girl. And the situation here is very, very challenging, as you can see, because she's very young. The area is a main aesthetic area. We have a critical defect because we have a lack of volume. It's not a single span, but is an extended dental space. 3 teeth are missing. We have a concavity instead of a convexity. So the case, in my opinion, was quite challenging. And this was the shape of the crest in the CBCT. You can see there is nothing. I could say we have no way to split the crest because it's only cortical. The height is good, and this is the good news, but we have no thickness. So we cannot split, we cannot do many things in this case. And I was very stressed about this case, so I also used the 3D printed model to analyze the quantity of bone that I would need. And what I decided to do in this case is to go back to a very old technique that in my hands is still one of the best techniques for regeneration, to take an autologous bone block from the ramus and to place in the area, in the receiving area. This is the situation after 6 months. We have a good amount of hard tissue, but as you can see, the situation of the soft tissue is not good, is very bad for the soft tissue. And at the moment of uncovering of the bone block, I decided to place 2 implants, 2 narrow implants, excluding the lateral incisor, because this patient is very young, and I can imagine that in time, probably I would change something, probably because of the shape or because of the color of the prosthesis. So I want to stay far from the most aesthetic region. So I placed the 2 implants and a connective tissue graft, again, because I don't need just volume of soft tissue. I need new keratinization. I need proliferation, something that I cannot buy. I can just take from the patient. And this is what we obtain using temporaries, removing the temporaries every week, remodeling the temporary to guide the soft tissue to take this shape, to press the soft tissue to gain some volume more, some papillas, even if the case is not ideal, is a compromise case in my opinion, but this was the moment of the delivery of the bridge, and this is after 1 year. And the patient is quite happy, even because she doesn't expose very much the soft tissue, and at the distance looks very natural. And this is after 3 years. If you look exactly at the papillas, of course, we could not obtain 100%. I asked the patient to do another connective tissue graft, but she was satisfied like this. She didn't want to have new intervention. We have also more extended cases, like in this case that was very, very with a severe atrophy, as you can see with the co-diagnostics examination. Again, we took a digital impression of the prosthesis, and we wanted to see if we have enough bone or how much bone we have to regenerate to place the implants prosthetically driven with such an atrophy. And in this case, we see that we have no bone in anterior side and no bone in posterior side. Well, so what it was possible, of course, was to move into zygoma implants. Probably the main indication in this case was zygoma implant, but the patient didn't want to have a narcosis, was a bit stressed about zygoma, receives very bad information about that, and she was asking me just to use more in-office techniques, not to do it with big surgeries. In reality, this is a quite big surgery. You see, we have fenestration in all the areas, and we have to graft into the sinus both sides. So what I decided to do in this case was to use 8 implants for have enough implants in case of failures of 1 or 2 of these implants. When we have such challenging cases, we have also to consider failures. And this was my planning, to use 8 implants for the prosthesis and 1 single implant in the medial line for stabilization of a removable prosthesis. The day of the surgery, I decided to open a big flap, do a double sinus lift, taking some bone from the windows and some bone from the nasal spine to mix with bovine bone. Was used this titanium mesh, customized titanium mesh, to keep all the bone inside and protect with collagen membranes all around. This was the healing, and you can see this ectopic implant in the medial line. It looks weird, I know. Is a 4 millimeter tissue level implant that stay exactly in the center, because this kind of cases we cannot use any removable prosthesis for basically 6 or more weeks. And this was after 4 months, and the prosthesis was attached only with an attachment in the center of the palate on these 4 millimeter tissue level implants. And after 6 months, we removed that implant that was failing. This was the CBCT that was taken after 6 months, where we see before the uncovering that we achieved a good amount of bone both into the sinus and into the crestal area. And this was the uncovering, placing the healing abutment. This was how we started and what we got at the end. And the trying stages and the final, this was still with the temporary, and the final prosthesis screw retain that was screw in the mouth of the patient. What is more nice, is my opinion, is to see how much bone we could obtain using this mix of techniques, sinus augmentation and titanium mesh, to obtain more volume. One of the most typical application of biomaterials in implant dentistry is for sinus lift procedures, and we cannot elevate the sinus all the time that we have an atrophy, because depending on the residual anatomy, we have some good indication for sinus lift and some bad indication. For example, when we have a crestal atrophy that is more important than the pneumatization of the sinus, in this case we have a contraindication in sinus lift. So the main indication is when we have an increase in the geometry of the shape of the sinus and not a big atrophy in the alveolar crest. Anyway, it's a very predictable technique. I think is one of the oldest regeneration techniques that we have in our hands. It's very predictable and is very easy to get bone into the sinus when the technique is correct. We see, for example, a very typical case when we want to use a tissue level implant for a molar. We have residual bone around 2 millimeters of bone. And in this case, the lateral wall was very thick. So this was just the end when I want to remove that bone to open a window because it's too thick, this bone. So I used the piezo surgery. I decided to remove that bone to have a better control of the membrane, of the Schneiderian membrane. And at that point, I can abandon the piezo surgery or the rotative instruments and use just the manual curettes to elevate the sinus. The technique is very old and nobody in Italy are interested to receive information about sinus lift, because most of clinicians who do implants, they are able to do sinus, or some are not interested in sinus and send the patient to me or to other clinicians. After elevation of the Schneiderian membrane, sometimes I like to use this kind of biomaterial. Is a collagen sponge we call Jason fleece. It's a very fast resorption material that help me to keep the membrane up during drilling. So I use it just to obtain a new floor, a new sinus floor that is very high. So I can drill without big tension, or I can protect the membrane, keep. After that, we can use a mixture, for example, of synthetic biomaterial and bovine, or even just synthetic. My first choice in sinus augmentation is Max Resorb, because I don't need a very long-standing biomaterial. I prefer to use a more easy to resorb biomaterial, especially when I do it in combination with implant insertion. So every time I place the implant, I don't need a very long-standing biomaterial. We first insert the biomaterial in the more mesial area, then we insert the implant, and we complete the filling after implant insertion with a more stable implant. As more I go on the window area, as more I can use a bovine material, because I will obtain a shield in the more external area. And after that, we can protect with the membrane. In this case, I use some antibiotic. This is, I think, nothing scientific. Is only something for control the stress of the dentist, not to improve the quality of the surgery. And we complete with a resorbable membrane to protect the area. In this case, was called Protect membrane, but Jason membrane would work even in the same way. Another sinus lift. This is the planning to take out a molar, to insert 2 implants after the healing of the extractions. Here, the sinus lateral wall is not so thick, so we proceed with a normal technique of remove the bone, check the mobility of the window, and we can go on keeping the piezo surgery instrument parallel to the bone to avoid that the instrument, that this rounded ball goes inside. Very often I try to remove that wall that is moving, but in this case I can even reflect inside. And we do an initial elevation with this smooth instrument, and then we continue manually the elevation. I go a little faster. We do an initial feeling like before with a synthetic max resorb. We do the first layer more mesial and more anteriously, and then when it's ready we can place the implant if we are sure to get enough stability. When I do implant insertion, sometimes I like to protect the membrane from the apex of the implant, especially when we use more aggressive threads. So I like to use this curette, this very smooth and big curette on top of the apex of the implant, so I can more easily distribute the pressure on the surrounded materials. You see this case. This was the initial situation before extraction at the moment of implant insertions. This was the post-sinus lift image, and this was the final result with the 3-unit bridge. In this case, I took in the mesial area a sample, and we have seen a good reformation of bone. Another case that shows you something that can occur during the surgery, it's not very uncommon, because normally we show all the cases that are perfect, but in this case we had a little complication. You see we have a little incision into the membrane. So we cannot start placing the biomaterial without taking care, because we can have an accidental insertion of the biomaterial into the sinus. So we want to prevent this risky situation. So after the elevation of the sinus, I need to protect this little incision into the sinus mucosa. So what I decided to do is to use a pericardium membrane, JSON membrane. You see, I insert inside. I need a big one because I want to keep one part outside, because as I will put biomaterial inside, I have to be sure to have the membrane in place without any displacement of the membrane. You see now it's covered. We have breathing of the patient. Patient is alive. This is the main important thing. And we can proceed now with a normal feeling with, again, the synthetic max resorb material. And after that, we will insert the implants. Everything is under control. And we want also to graft on this apex of this implant that was accidentally exposed. We have no perimplantitis in this case. The implant was an old implant that when I elevated the flap, I found these threads exposed. So again, in this case, I don't use a synthetic material. I use a bovine material because I want to have a very long-standing material for maintaining the volume, and a JSON membrane. In another case, more challenging, I combined the sinus sleeve with the regeneration. We have this failure of this very weird solution with a single implant with a cantilever. This was, I think, a crazy solution. we have a very big defect in bone. So what I wanted to do to make a vertical augmentation in that area and the sinus lift in the posterior area to place 2 implants instead of a single one. So sinus lift, I used again mucoderm as a membrane. You see we have a little exposure of mucoderm in the area of the extraction of the implant. There was 2 BLX implants in place. 1 implant was used for immediate restoration for aesthetic reason, and the sinus lift implant, of course, we left for many months before loading. And finally, this is the final restoration. You see how we started and how we finished in these 2 X-rays. And the bovine bone was very, very effective to maintain the crestal height of the area of atrophy for the implant failure. Then we arrived to soft tissue management. As you all know, soft tissue is very important, especially for long term of success of the implants. Every time we don't have the correct volume or the correct keratinization, we can have problems of cleaning for the patient, or we can have even biological complications, or we can have aesthetic complications. So what we want to obtain always at the end is a natural keratinization and a natural volume for the soft tissue. We have the connective tissue that is, of course, our gold standard. We have all fantastic features of the connective tissue, especially when we want to obtain keratinization and proliferation. But we have also an alternative that is the porcine dermis matrix. We have a lot of good features. We have big quantities that we don't have with autologous connective tissue, and it's not so invasive like taking connective tissue. Of course, connective tissue is the most predictable solution when the patient can receive this kind of intervention. You see how the proliferation works. We start with this situation, and without any bone grafting, we obtain such a big volume of soft tissue. Or this case that was made by my friend Eugenio Longo, we started with this situation of very, very dramatic problem with the soft tissue, and just using soft tissue obtain this shape for the restoration. The implant is not yet placed. Probably we will not use an implant in this case, but we obtain an ideal shape of the soft tissue. This is not probably yet possible with biomaterials. We need the connective tissue from the patient. But the porcine dermis matrix works brilliantly when we need a protection, when we need volume. We can even use as a membrane, as you have seen before. We have a rapid revascularization and integration, and this is fantastic. It's very effective. It's very easy in the hands of everybody. We have the complete remodeling into the patient own tissue, and the resorption is about 6 to 9 months. Can be easily shaped, applied, and fixed. And how we use in our daily practice. In cases like this, where the tissue is not bad, the tissue is still possible to do without an increase of keratinization. I just want to have a little increase in volume, so I insert one slice, I insert my healing abutment, so I don't have to disturb the tissue again, and we finalize the case. If you want a little more, you can bend it. You can use the same porcine dermis matrix, but you use not in a single layer. You bend it to have a sort of sausage that you will insert under the soft tissue, and you can close, leaving a little empty space, not a primary closure, because we want to get more keratinization. You see a good case with good keratinization. We are only missing some volume. We can graft with the hard tissue, why not? But if you can use a narrow implants, like in this case, we use a 3.3 millimeter implant that stay completely into the bone, it's sufficient to insert a little slice of mucoderm, and we obtain, you see, a good amount of volume with a very low risk in this case, because this material is very difficult to get infected. It's very stable in time, so we obtain a very good quantity of volume if the keratinization is still okay. A way to stabilize, this is not an implant case, of course, but a way that I like very much for stabilization is to use sutures to the periosteum. So we come from the pellet, we take the periosteum tissue and we go back to the pellet. So we are free to move the mucoderm in the correct position. We can also do with implants. There's another possibility to mix the mucoderm with Emdogain. Is a quite expensive solution, I could say. We tested for a paper that is in preparation. The study was already done. We have some scientific base for this combination because the Emdogain is able to stay on the membranes. And this was the study that I did with Luca Bonino and Nicola De Angelis to use tissue level implants with mucoderm Emdogain in a single stage, no bone graft, single layer of mucoderm, not a double layer, single layer. And we evaluated the volume with computer programs. The technique was very simple: a single layer, healing abutment, and measure of the volume. This how we studied the changes in volume, and we had some results very, very good with improvements of around 1.5 millimeters in volume. In some cases, we obtain even impressive increase. We don't know why. In some cases, we obtain even 7 millimeters of volume more, like in this case. That was very, very impressive for me. The paper is in preparation, not yet in publication, but I hope we will publish soon. You can see another case with no volume in the posterior area of the mandible. We provide for rehydratation of the mucoderm that is very, very rigid, and rehydratation was made with Emdogain primarily to leave Emdogain to enter inside the mucoderm. And Emdogain is not enough for rehydratation, so we need few drops of saline solution to have the highest percentage of Emdogain during the rehydratation. The technique was to use few drops. You see we have a progressive rehydratation with the minimum quantity of saline solution. And this is no bone grafting, only grafting with Emdogain and mucoderm. We had after 12 weeks with a temporary good situation. This is how we started, and this is how we finish, just taking care about the soft tissue. Another application of biomaterial during our long journey into the biomaterial applications is at the moment of extraction. There are many, many papers who demonstrated what happens during the healing period after tooth extractions. We have in most of cases, a resorption of the buccal plate vertically and horizontally. And unfortunately, the implant placement is not sufficient to maintain bone. Again, when I started in the half of the 90s, the main idea was place an implant after one extraction so the bone will not resorb. And this idea that we had was not correct, because we all know that resorption occurs anyway, even if we place an implant. And resorption is more and more severe as more thin is the buccal plate. So when you have less than 1 millimeter in the buccal plate before the extraction, you have a resorption that is 3.5 greater than in case of thick bone in the buccal plate. And unfortunately, most of anterior area has less than 1 millimeter of bone. And this bone is, we call bundle bone, that is related to the periodontal ligament, is not basal bone. So when you remove the tooth, you remove the periodontal ligament, you sacrifice the vascularization, and you have a natural resorption of this buccal plate. And since many years, people try to maintain this bone using what we call ridge preservation, alveolar ridge preservation. And we have some data who show that this technique is quite effective to maintain the bone better than a natural healing. And what we normally observe in systematic review and meta-analysis of this technique is that we can obtain 2 millimeters of maintenance more instead of a natural healing of the socket. But this technique is not free of problems, is not free of complications, because we all know that as you graft with biomaterials, you have to wait up to 6 months. In the next days, you will see, tomorrow, I think you will see my friend Alfredo, that will show how we can use different techniques to preserve bone after extraction. And looking at the literature, we observe that using this technique, we can maintain a little better the situation of bone. We have even different options, not only the alveolar ridge preservation. We can even decide to take care just of the stabilization of the blood clot without using biomaterial and wait less time. Instead of 6 months, we can wait 6-8 weeks and go back for a GBR technique. Or we can wait a longer time with the natural healing and taking care of the volume with a new GBR technique, or doing an alveolar ridge preservation. So we have different options: spontaneous healing, socket filling without the membrane, or a complete alveolar ridge preservation. And we can perform all these techniques using autologous bone, homologous bone, heterologous bone, or synthetic. We will see some cases with different techniques. We have different options, and we don't have a good option and a bad option. We have different cases with different opportunities of treatment. Let's go a little faster, sorry. Okay, sometimes, I could say many times, I prefer a spontaneous healing after extraction to do not an alveolar ridge preservation. Let's see, for example, in which indication I like to do. For example, when my extraction is in case of an acute infection or an active periodontitis, or when the bone filling is already spontaneous, very predictable, or when I want to go back fast. I don't want to wait 6 months. I want to go back after 6-8 weeks and do my treatment with a better situation. Let's see, for example, this case. This is a patient with a serious problem of periodontitis. We have many questionable teeth in this mouth. So if I decide to take out this tooth, for example, only, and not to take out all the neighbor teeth, I don't feel okay. I don't feel comfortable to use a GBR technique in this case because I have contamination. Some teeth are still questionable. So it's too risky to use biomaterials in this situation, even if I have to do an extraction. So we will do an extraction, and my friend Eugenio Longo will take care about the periodontal treatment in this patient with different treatments. And we simply wait. I'm sorry for this, temporary is very bad. Anyway, I simply wait. I did nothing in this case, simply spontaneous healing. We decided to wait longer because we wanted to control the patient if she was a good patient for implants, as she's coming from a periodontal problem. So we decided to graft with soft tissue, with mucoderm, just to improve the situation. And you see, after that, we decided to place one implant after around 1 year, placing one narrow implants, and again grafting with mucoderm to improve the volume. And you see how we started and how we finished, only with soft tissue grafting and waiting a normal healing after infection, using mucoderm and using endogain. In this case, we started from this situation. We kept the neighbor tooth. We extracted only that incisor and waited a normal healing, taking care about the infection, taking care about the periodontal problem, and waited a longer time without doing big things. This is after 1 year, the control that is still stable. In other cases, I like to use the porcine dermis matrix for stabilization. You see, I have a good predictable defect. I have a lot of bone. I don't feel very risky to leave a spontaneous healing. I just want to stabilize the blood clot, so I leave exposed the mucoderm. I wait for a healing, and when the bone is healed, I can place a standard, a wide implant, in this case, a wide neck implant. Again, stabilization, waiting for a normal healing of the bone just with a blood clot. After a couple of months, 2-3 months are sufficient in this area, and we place an implant and the finalization of the case. Another case, you see the technique. I normally try to insert the mucoderm after extraction, after removal of granulation tissue. I want to stabilize the blood clot. So we don't want to use biomaterials in this situation. So I designed the mucoderm as a surfboard to get inside the periosteal tissue, stabilize with 2 stitches, and when more stitches to keep in place. And you see then the normal healing and the implant placement after 3 months and the finalization of the prosthesis. In some other cases, I prefer to use this technique using also bone fillers, because in some cases where the defects are bigger, I especially like this technique for second lower molars, where the formation of bone is very slow and sometimes not very predictable, or in the upper canine where the defects sometimes are huge for spontaneous healing. So, for example, in this case, I have a very old fracture in this molar. I decided to use Max Resorb, that it goes away after 3-4 months. Use mucoderms, and I used in this case a collagen sponge Jason fleece on top to obstacle to give more time for resorption of the mucoderm. This was the healing after 1 week. Looks not very nice, but in reality inside is working. This is after 6 months when I decided to place an implant, and this is the final outcome with a good maintenance of volume and a good final outcome. In some other cases, we need to do the most complex solution with biomaterials and a membrane, and this we do when we have major defects and we don't want to have the soft tissue invasion. And sometimes we do for pontics, for example, when we want to exclude the possibility to place an implant, or for lower second molars again, or upper canines. We have two possibilities: one to use membrane or matrix, or even to use the epithelial connective tissue from the pellet. We have some good sides and some bad sides for both techniques. I think that the epithelial connective tissue is useful only if your skill with this technique is very, very high, because we have many risk of necrosis and sometimes is quite invasive. This case again from my office with Dr. Eugenio Longo, used again in case of anterior case to get some proliferation together with some bovine bone. And you can see how the soft tissue grafting, the soft tissue grafting from the pellet is not passive, is active, it proliferates. You can get more keratinization, and this was at the moment of implant insertion. You see we have an ideal amount of bone and an ideal soft tissue anatomy to receive one implant. So to use again the connective tissue is a possibility when you want to improve all the situation, not just the bone. You can do together with the bone to obtain the ideal condition for implant placement after 6 months. We have another possibility that sometimes is very interesting to me when, for example, we want to avoid the loosening of keratinized tissue. We don't want to lose the keratinized tissue that is present. Let's see, for example, this case. We have 2 failing molars, but we don't want to have a primary closure because we don't want to lose the keratinized tissue. So a possibility is to use this sort of barrier that is not resorbable, that is called PermaMem, that will stay around 1 month to protect the blood clot formation. In this case, was placed on top of bovine bone. We see after 1 month, 1.5 months, I don't remember, I decided to remove it because it was not exactly stable. Under that barrier, the soft tissue looked still a little bleeding, but you can see that we could maintain some bone and to have a crystal sinus augmentation, in this case to place a single BLT implant with a a very favorable condition of soft tissue around. So this option, I think, is very useful when you don't want to have a primary closure. You want to wait in a posterior area, a spontaneous healing of the area. Let's see, for example, one case, very interesting, I think, because this young patient had at the same time the indication for extraction of the 2 lower molars at the same time. This is not very common. And we decided to do 2 different techniques. In one side, I decided to do an alveolar ridge preservation. And you see I had a partial failure of that procedure after 7 days. I had an exposure of the bovine bone, of the max resorb, and you see, even with this partial exposure, after 6 months, the anatomy was very, very maintained. So I could, with a very simple incision, to insert a wide neck implant in this area after 6 months. On the other side, I left a spontaneous healing without bone grafting, without anything, just spontaneous healing. And you see how after 6 months, we have this concavity. So we need a bigger intervention, not so big, but we need to elevate a bigger flap to insert the implant and again to treat the concavity with cerabone, so bovine bone, and mucoderm to obtain a convexity instead of a concavity. So the same case, the same patient, on the left side, she had an initial bigger intervention and a second very, very mild intervention. On the other side, in the same patient, we had a very simple extraction with no bone grafting, but we need bone grafting at the moment of implant insertion. This is just to say that it's very difficult to do without grafting nowadays. Another possibility is the immediate implant insertion from ITI. We all know that we have some little advantages to place immediately the implant. We have a reduced number of surgical procedures. We have a reduced overall treatment time, but we have also many, many disadvantages. For example, the side morphology may complicate the optical placement and anchorage of the implant. We can have a lack of soft tissue, a potential risk of lack of keratinized mucosa, and many times we have to graft in this case, I could say in most of cases. And the requirements for this technique is to insert the implant prosthetically driven, not driven by the socket, but driven by the prosthesis. We need to reach a sufficient primary stability that is not always easy to get. We have to consider that after implant placement, we will have some remodeling in bone, some resorption, especially in the buccal plate. And we have to take care about the soft tissue, like always, and to consider a higher risk in a biologic point of view, and that most of time we have to graft because we have some jumping distances between the threads of the implant and the walls of the socket. The survival rate of immediate implants is quite good. It's only 3% less good than the delayed implants. And we can have very often the need of biomaterial when we have more than 1 millimeter of jumping distance. Let's see, for example, this case. I extracted one premolar. I decided to place one BLX implant that is very, very easy for high primary stability, and I decided to use a very simple device that is a healing abutment that goes inside a little disc of mucoderm. You see, the mucoderm seals exactly the socket. I don't need any suture in this case. This is not very common. This is the healing time and the quality of the soft tissue that we get. We can see more in details. Very, very simple technique. We close all the empty spaces, so we expect that the blood clot works for us. And this is the final quality of the soft tissue and the prosthesis and the final X-ray. Another possibility where we have more jumping distance. This was the situation. At the moment of implant insertion, we have this empty space that is too big for just wait for a spontaneous healing. We have too much distance between the implant and the bone, so we risk an invasion of the soft tissue in this case. So what we can do is to graft with bovine bone in this case, or we can use synthetic. Anyway, it's better to fill this empty space. And then we can, even in this case, protect with porcine dermis matrix. So we will fill with bovine. Magnification is very important when you don't elevate the flap. I like to use the microscope every time I don't want to elevate the flap. I have to control from inside, so I need magnification and illumination. And after that, again, we can seal with this very simple disc of mucoderm. We try to keep the mucoderm as more as possible inside, not too much exposed. You see, after that, I try to keep inside. I don't want to have big exposure of the material. And as the material is so elastic, I like sometimes to use sutures to stabilize it in the proper way. This is what I did, using a couple of stitches just to keep the mucoderm in place. This is the healing after 1 week. And the final situation and the soft tissue at the moment of crown delivery. Sorry, go a little faster here because it's too long, this video. Okay, another case, very interesting for me, was that one, a very young patient. He fell and broke 2 perfect teeth with no any pathology, just because of a trauma. He had these 2 horizontal fractures in the roots, and unfortunately I was obliged to remove these roots because the line of fracture was very below, under the bone level. So I took out, I inserted 2 implants. There was a remaining distance that was a little too much for spontaneous feeling, so I used bovine bone and again dermis matrix, and this is the closure with the healing abutment, and this is the final delivery of the crowns with a very good healing of the bone and the soft tissue. Go a little faster here because I think otherwise we I have no time to see all the cases. Yeah. Let's move to something that probably is more attractive for some of you, that is the management of anterior cases. Our Moses for these anterior cases is the laws of our anterior cases is in ITI Treatment Guide, volume 10, where you find these very, very useful principles to understand if the risk is low, is medium, or is high. So all the cases I will show you will be together with this guide. And as you saw before, even when we talk in post-extraction, we have to respect all the rules. And very often we have to prepare not in the center of the socket, like in this case, but a little posteriorly to give space for biomaterials to maintain the volume between the buccal plate. This is unfortunately not always possible. Remember that we have some cases where we have no bone behind. So when we face an anterior case, when we want to do a fresh socket implant, CBCT is very, very important to detect if we have the possibility to insert an implant a little bit more posteriorly. And we have in these cases, in these anterior cases, more risk of complication. For example, we have an aesthetic risk in case of resorption of the buccal plate. We have, for example, in this paper, a buccal recession in around 11% of cases. That is not acceptable. For example, for my clinic, I think if I have 11% of aesthetic problems in anterior case, I would be always with a lawyer close to me. So I cannot accept this kind of risk. I have to plan the cases in the right way. And planning is a key factor always, but especially when we work in anterior cases. For example, I will show you this case that we saw in my office. This female was 17 years old. She had a traumatic fracture of a central incisor, that is the main aesthetic region of the mouth. And the colleague, one colleague in my region, decided to make a post-extraction implant at the age of 11 years old. And when we saw this patient, she was very upset. She was very stressed because she wear for 2 years one removable temporization, because the colleague was not convinced to proceed with the prosthesis with this implant. And the situation, as you can see, is very, very unpredictable. Dr. Eugenio Longo took care of this patient, and we evaluated this implant, but in our hands, this implant was hopeless. And we decided to proceed to extract this implant because in this case, in our idea, our point of view was that was not predictable to leave this implant. So we decided to graft and this case was published in an aesthetic review, in an international aesthetic review, was performed without an implant with a simple Maryland bridge after soft tissue grafting. But it was just to show that if you make the wrong planning, you make everything wrong. And immediate restoration implants is indicated for many reasons. In reality, most of these reasons are not important. For example, decrease the number of the surgery is not the biggest problem. Decrease the time of treatment is not a big problem. Psychology of the patient is not so big, because when you have a failure like before, the psychology of the patient is worse with an implant than without an implant. But the main reason that I consider is to maintain the soft tissue architecture in this patient. We have many disadvantages. We increase the complexity. We have a frequent grafting techniques. We increase the early failure risk. We need a high stability to try to have an immediate restoration, and we need skill and experience of the clinician. Let's see, for example, this case. This is very favorable. We have a fracture of one central incisor. The fracture is below the line of bone, so I prefer to treat this case with an immediate implant, a filling of the empty space between the buccal plate and the implant, and if I have enough primary stability, I can use a temporary that is made of composite, and I deliver the same moment of implant insertion. Again, I use Mucoderm as a very good device to seal the space between the temporary and the internal side. This is the healing after osseointegration, and this is the final crown that was delivered with the X-ray. The decisional tree, if it's possible to do an immediate placement and immediate restoration in the anterior region, I need 4 conditions. I need to get a high primary stability. I need to exclude patients with big lateral forces like deep bite. I need a good compliance of the patient. The patient have to understand that we are doing something that is risky, so he has to exclude some food or some forces on this temporary. And I want to have a good condition in hard and soft tissue. When all the 4 conditions are respected, I can do an immediate restoration. In case that, for example, I have a deep bite or I don't trust so much in how the patient will treat my implant, I can switch to a very, very good solution that is the customized healing abutment. Or in case that other conditions are not respected, I can stage the implant, or I can submerge the implant if I want to do at the same time. Let's see, for example, when I say about the compliance of the patient, it was a patient, I did this temporary, and the patient came back with a broken temporary. So the implant was not integrated yet, and the patient already broke the temporary. I don't know, in South America, in Italy, when they break one temporary, they always say that did it with broth or something very soft. I don't know if even in Latin American people say the same silly things. Anyway, we were lucky, we didn't lose the implant, and this is the final restoration that was done. But, for example, if I have different chance, I like to use this different chance. This patient, she lives in Florence, she's Russian, quite young, and this was the situation. Evaluation of risk was not the best. And she has a fracture in a central incisor, and she told me something very, very interesting. She said, I want to replace also the neighbor crown. This was music for my ears because I could avoid any kind of risk. I did a crown with a cantilever. At the moment of extraction, I decided to use an immediate implant with a customized healing abutment to maintain the shape with Mucoderm to give the ideal shape for this case. So this case was very, very predictable thanks to this healing abutment with the sealing of Mucoderm with bovine bone. This was the moment of the end of the surgery. This was after 1 week. You can see how the soft tissue maintained the shape with this cantilever that is in close contact with the heel abutment, but without any loading on the heel abutment. After 2 months, I proceed for the final impressions for both, for the implant and for the natural tooth, and this was the day of the delivery. This is after 1 year after the delivery. Another case, more challenging, I could say, where I have to extract the 2 central incisors, and this was the initial situation. The planning was to extract the 2 central incisor, place 2 lateral incisor, and do an immediate restoration for the 4 incisors. This was the day of the surgery, elevating a flap, using a temporary guide for insert the implant guided by the prosthesis and have a sort of template, a sort of guide for placing the temporary. 2 implants were placed in the lateral incisor region, and the temporary bridge was blocked to the temporary abutments. After that was placed cerebone, the bovine bone, to maintain the volume of the central incisor, and mucoderm to protect with a sort of complete alveolar ridge preservation the 2 central incisor area, and to increase the volume in the buccal side of the lateral incisor. This was the post-op with a temporary. This was after 2 weeks. This was after 2 months. And you can see how the shape was moving from one situation to the other. And finally, the good contour of the soft tissue. This was after 75 days from the beginning to the final contour, and the delivery of the final bridge of the central incisors. This is how we started and how we finished, without big resorption, big changes in the hard and the soft tissue, and I could say an improving of the volume in the lateral incisor thanks to the mucoderm grafting techniques. Of course, we have also very favorable cases like this one. This is what we call in Italy Sunday case. Is another young man who's living in my area. You can see here the green stripes are fantastic. We have an ideal situation, and this case is quite old, but you can see we have all the conditions for doing an immediate placement and immediate restoration. The case was studied to see if there was enough bone for immediate placement to reach a high primary stability. We wanted to respect the distance between the implant and the buccal plate, giving space for grafting with bovine bone. The implant is placed exactly 3 millimeters under the gingival margin, respecting the rules. And you see we can control with microscope from inside the distances. The place was filled with bovine bone, with cerebone, and finalized with a temporary. Probably in your question you will ask what is the orange or yellow fluid. This is antibiotics, but it's not necessary. It was part of a study that was not carried on because was not necessary to use antibiotics. This is the final ceramic delivery. At the time there were no component for very easy screw retain solution. This is after 1 year, and this is after 30 months. You can see that the situation is still aesthetic and the stability of bone is fantastic. And sometimes what is the problem with our cases is not the hard tissue, it's the soft tissue. This lady, Brazilian lady, she also lives in Florence, and she has this failing central incisor, and the patient is asking for removing this central incisor and doing something fixed. And when I saw the case and evaluate all the problems, I said, okay, here situation is very difficult, it's very risky. If you want a good aesthetic, we have to work on 6 teeth, not only in one tooth, because we have different levels, different shapes, space. We have a crown in the neighbor lateral incisor. So I cannot achieve a good aesthetic without moving many things. She said, no, I want just to work on this central incisor. I will accept one compromise result. I said, okay, let's do it if you don't care so much about aesthetic. Anyway, I decided in this case to place this implant immediately, to use bovine bone to maintain the buccal volume. And in this case, I cannot use as first choice mucoderm, not because mucoderm has some problems, but because has no possibility to proliferate and has no possibility to improve the keratinization. So I took some connective tissue from the palate and I inserted. I did an immediate restoration, and this is the end of the surgery. You can see during the healing, looks not perfect, but we see in time some improvements. This is after 1 month. This is after 2 months. I decided then to deliver a ceramic crown. You see a bigger volume, and you see before and after we had some improving in thickness of the soft tissue and improving in the levels of the middle line of the crown. And after 3 months, I could say that it's even better. This is after 6 months when, in my opinion, it's trying to be better again. And we all know that the soft tissue from the tuberosity or from the palate, it grows. So as more we wait, as more we will have a good result. The problem we had is that a second problem on the lateral incisor. So again, was necessary to insert an implant at the moment of extraction, and the same technique with connective tissue grafting. This is a BLX implant in place, trying to respect the ideal position for the lateral. The stability was very, very high, so it was possible to do an immediate restoration. This is the control from inside. We can see that we have some space between bone and the implant. The implant is 1 millimeter, even more below the level of bone. And now we want to graft with hard tissue and soft tissue, bovine bone and soft tissue, to have some proliferation in time. So what we expect is to have an improvement even in this case. I delivered, even in this case, one temporary crown. This is after 1 week of healing. Also in this case, we will wait a longer time for the proliferation of the soft tissue. Last 2 cases, and this is a Japanese patient, not so young. and she has many red points, a high-risk case. And in this case, I was too much positive, I think. I had probably the wrong approach. I extracted the tooth, I placed the implant, I did the GBR technique, and this was the result. You see the healing that looks a concavity. And at the moment of uncovering, I used a temporary screw retain, and you can see how bad is the situation of the tissue. I was very, very sad for this initial result because I expected too much from my experience and from my skill. I did too many things at the same time. And this was the moment of delivery where the situation is still not good. And the patient was very, very friendly. She told me, thank you. You know, she was a real Japanese lady, very polite and very friendly. But if you have such a result in a young lady from Sicily, for example, she could kill you with this result. So the situation was, in my opinion, very bad. The patient probably she was not able to see very well, or she was too kind and she accepted. Fortunately, after 3 years, the result is a little better. I could say it's sufficiently good for an old lady, but not sufficiently good for a young patient, in my opinion. So after this bad experience, I decided not to do too many things at the same time. And you see, for example, this patient from Venezuela, she lives in Florence too, like all these people. She's younger and she's very, very, very interested in aesthetic. You know, South Americans are like Italians. They like aesthetic. They pretend aesthetic. Is the reason they go to a dentist. In Italy, people come to a dentist for pain or for aesthetics. So you cannot compromise too much with aesthetics. And this patient had a failure central incisor. So there was an acute process. I decided not to do too many things, just to make the blood clot stabilization with mucoderm and to use a Maryland bridge to stop the situation, not to do too many things, not to place an implant. And you see also in this case, I have during the healing a concavity, I have no hard tissue grafting in this case. It's a spontaneous healing, just blood clot stabilization. But this concavity is not a problem because my implant is not yet there. So every time the implant is not there, you have still many possibilities to solve. I tell to my students, until you don't place an implant, you are fiancé with the patient. When you place an implant, you are married with this patient. So we have to play it at the right moment, not before. So after 3 months, I did a CBCT and there was enough bone for placing a narrow implants. I don't need big stability because I'm not doing an immediate restoration. I want to improve the volume, not the keratinization, because keratinization is enough. So as I don't need keratinization, I can use mucoderm in this case. I would be too much invasive to take some connective tissue in this case. So I improve the volume, I use the customized healing abutment, and this is with a temporary screw retain to guide the shape, and finally, just with soft tissue grafting, with no hard tissue grafting and the narrow implant, I have a good amount of volume, a good volume for finalize the case. And this was after 6 months, the patient was quite happy. So the messages we can take home. Arturo, I'm sorry, telling you not to make too many questions. we stopped completely the questions, but if you want, we can make after these conclusions.
Just give the conclusions, then we can have a little discussion.
In implant treatments, every year I increase the number of grafting procedures because I very often have to graft the bone, other times I have to graft the soft tissue, and other times I have to do both things. Second point is that planning, starting from prosthesis to guide the protocols. So we start from the final outcome that we want to achieve. And third point, to know the techniques, to know the biomaterials, and to understand what we can achieve, what is realistic, what is not realistic, and to communicate with the patient all these informations, because some patients have a lot of expectations. So we have to know in advance the kind of outcome that we have to reach or what is not possible to reach. I thank you very much for this fantastic opportunity to be with you. And these are some of the places where I work, my office, the university. Sometimes I bring in São Paulo in Brazil many friends since I think 11 or 12 years to make courses with me and with the staff in São Paulo. And for the University of Genova, I travel a lot in all over the world, except now with COVID pandemic situation, I don't travel and we do only online courses. Thank you very much. And Arturo, please, I'm more than happy to answer to some questions.
Yes, we have millions of questions, Massimo. Thank you very much for your presentations. Was as usual amazing. And I'm going to choose some of the questions because there are really many. So I think we can have a
and there's my email address. In this slide, there's my email address. So if someone has a question that I cannot answer, please send me an email, and trust me, I will answer to you personally.
So there was a few questions about the use of a membrane, and in particular, how you, first of all, if you fix it, and if you fix the membranes in a GBI, for example, how would you proceed? So do you suture it? Do you use pins? Do you leave it without suturing? This was, let's say, I'm summarizing 5 or 6 questions here.
Yeah. I think I suggest to you, in my opinion, the most easy way is to use pins. So if it's only for fixing the membrane, for stabilization of membrane, I think pins are the most easy way. If, on the contrary, you want to obtain a double advantage to stabilize the membrane and passivate the flap, I think this technique is very useful. I showed you before. You use this kind of suture because at the same time, when you close the stitch, you passivate the flap down. So we have a double advantage: stabilization of membrane and passivation of the flap. But if you just need the stabilization of the membrane, pins is my first choice.
Okay. Still with the JSON membrane, you showed some very cool sinus lifts procedures, but there was a question about, instead of doing a sinus lift, if I want to do a vertical augmentation, can I use the JSON membrane? And on a related note, can I do a sausage technique with JSON?
Yeah, Yeah, Jason, I think is very, very indicated for sausage technique. I'm sorry, I didn't insert any case of sausage technique. I did it, but I have no slides on that. And I think that the kind of resorption, the slow resorption, and the kind of handling of Jason membrane is very good for sausage technique. So vertical augmentation, you all know that is the most challenging application. So we have no evidence of long-term stability of the bone that was augmented in a vertical dimension, but Cerabone and Jason membrane, I think, is a very good couple of devices for these kind of techniques. Of course, you need a very high skill in passivation of flap, in stabilization with pins, and mixing with autologous bone. I think these factors are mandatory. The same, we need to have a good control of mechanic factors.
Yeah, I mean, especially if you're doing a big defect, then the autologous bone becomes very crucial for the nice outcome.
50% with Cerabone.
Still with the with the sinus lift, there was one case you shown with a perforation of the Schneiderian membrane, and the doctor was asking, I think it's the same case, why did you use the synthetic biomaterial inside the sinus, and then you use the bovine bone to protect the surrounding?
Yeah, because inside the sinus, I think, is the ideal condition for a synthetic material, because regeneration is very predictable. You have a box of bone where a cheap bone is natural, is spontaneous. You just need to maintain a volume for some months, but you will get bone for sure. I think after many, many years, sinus lift is one of the most predictable procedure, and all the companies of biomaterials use the sinus to show how good is their material, no? Even if you place nothing, you get bone. So all the companies, even if you have a very bad biomaterial, you put it in sinus and everything heals.
Of course, no? Yes.
On the contrary, when you want to maintain a volume, you need something a little more effective, no? So in the internal side, where it's more predictable, I use the most resorbable biomaterial, because I need to know is a critical defect, the sinus lift, no? You have seen cases where I have only 2 millimeters of remaining bone so I have to be sure that what I have in the sinus at the end is real bone, not something that is a mosaic where 80% of biomaterial and 20% of bone. I want to have 80% of bone and 20% biomaterial. So a most resorbable biomaterial tell me with an X-ray that what is mineralized is bone. On the contrary, in the external side, it's not a critical defect, but I need volume. So I need a long-standing material who impede the invasion of soft tissue. So the external side on the area of the osteotomy, I think bovine bone give me the opportunity to have a shield to block the soft tissue to invade the sinus space. And the same when I want to cover the thread of an implant, bovine bone is more predictable for maintaining the volume, because it controls the pressure of the surrounding tissues, is more resistant to the pressure.
And there's another very, I think, hard question to answer in a few words, but one of the doctors asked you, if you have a preferred protocol to treat periimplantitis.
Oh, yeah. This is very difficult to answer. How many hours do we have?
Exactly. We do another event for this question.
I think, yeah, first of all, we have no scientific protocols for periimplantitis treatment. Many friends of mine, they simply retrieve the implants. Of course, we retrieve the implants that we didn't place, yeah? Because if someone else put the implant, we can retrieve the implant. But when it's our implant, sometimes we try to solve the problem. And what became quite clear in my practice is that if half of the length of the implant is infected, it's better to retrieve the implant anyway, even if it's my implant. Yeah? Even if I'm the father and the mother of that implant, I retrieve it because I need less time to start again instead of trying to treat this implant. I need more time, more expensive, and it's not predictable. But if I have an initial periimplantitis, what I do sometimes is simply to clean the surface. That depends on the kind of surface. If it's a smooth surface, it's very easy to clean. But there are some kind of surfaces that are almost impossible to clean. So I simply remove the threads, clean everything, polish everything. And my ideal biomaterial for these cases is connective tissue. I also did with mucoderm and was very good. But
Okay.
it doesn't proliferate, it doesn't give you more keratinization. So during periimplantitis, very commonly, you don't have enough keratinization, you don't have the good quality of the soft tissue, so we need connective tissue.
This connects perfectly with the next question I wanted to ask you. There were a lot of questions about mucoderm and soft tissue management. And one of the most frequent questions was, where is the limit? Where do you choose mucoderm, and when it becomes too challenging to use mucoderm and then you prefer to use the soft tissue, the autologous soft tissue?
Yeah, mucoderm is, as you know, Arturo, is one of my favorite biomaterials ever, no? Not only in this company, but in all the market of biomaterials. But some colleague tried to use, and they were not happy about the results, no? And then when I asked them, but what did you do? What did you want to do to obtain with this material? Oh, I had no keratinization at all, and I placed the mucoderm. I didn't obtain keratinization, but it's not in the indications. So, mucoderm, the limit of mucoderm in my practice is keratinization. If you want stability of the soft tissue, if you want volume, mucoderm is my first choice. As you have seen in the last case, I had enough keratinization. Why should I take some connective tissue from the pellet that the patient will complain for 15 days probably? If keratinization is okay and I just need volume, mucoderm is my first choice. If I have even 2-3 millimeters of keratinized tissue, mucoderm is still my first choice. If I have less than 2 millimeters of keratinized tissue, I try to think to connective tissue. If I have no keratinized tissue, it's mandatory to use connective tissue or epithelial connective tissue. The same if I need increase in the height of the soft tissue, mucoderm is not my choice because it cannot proliferate. If, like in the case I showed before, I need to bring the tissue down on the crown of the central incisor, I cannot try with mucoderm. Has no sense. Is unpredictable. I need to use something who proliferate, who is doing something for me. This is the limit. So the limit is clear to me, but many clinicians, they expect too much because they are not confident for taking this connective tissue. So they hope that Mucoderm solve all the problem because they want a smart solution, no? But there is no smart solution for the soft tissue. You have, before you had connective tissue or nothing. Now you have connective tissue, Mucoderm, or nothing. And in my practice, connective tissue is not for all the indications. But the same, I want to improve a little. So Mucoderm, it covers probably the majority of my indications.
And since we are talking about this, would it make sense, or this is the way of thinking? One of the questions was about what is the advantage of Emdogain? So can we imagine Emdogain giving a little push to Mucoderm in this sense? Or why do you use Emdogain in that study with Mucoderm? What is the advantage?
Emdogain was, I think, one of the best biomaterials since many years. I think is probably it's in the market since probably 20 years, and it works perfectly in the soft tissue healing. Is very good for perio. We didn't have indication for implants. The main indication was for perio. Straumann asked me to try this combination with Mucoderm, and I thought it was probably not sufficiently scientifically based to do. It was expensive. It was a biomaterial not normally used for implants. But as I started to do for this study, for this paper, we had very good results, and we analyzed the volume up to 1 year, and the results were stable. So I don't have exactly the idea how much is the importance of Emdogain and how much is the importance of Mucoderm. What I can say is that there's a learning curve in managing these biomaterials. Even if it looks easy, in reality it's not so easy. We need a good stabilization of the biomaterial. But Emdogain improves the quality of the soft tissue, improves a little bit the volume, not the keratinization. So again, will not expect, I think it's not correct to say to participants of this Congress that if you do more things, you will obtain more than that. Look at the quality of the soft tissue, and this help you to decide when Mucoderm is not enough. But if you have a sufficiently good soft tissue and you want to improve the volume, for example, Mucoderm is very good. With Emdogain, in my opinion, is even better. But I cannot yet tell you obtain 50%, 50%, 40%. We don't know. We had very good results with this combination. So we expect that our paper and following research will tell you which is the weight of every component of this thing. If it's enough to use Mucoderm, if it's enough to the combination, if it's too much, we don't know.
Maybe next year when we do a real event in Mexico, maybe you can give a better answer with the new data you have from the article.
Yeah.
So I would suggest that we proceed to the Bote solution last part of our day. So simply to remind the participants, we ask you to send us some challenging cases that then today Massimo Frosecchi will solve, and tomorrow Dr. Caiazzo. So we have, I think, time for a couple of cases. So maybe we can go to the first case, and Massimo will comment on this. Next slide, please. Yes, this one. Thank you.
Yeah, so there's only this image, so we try to work with our fantasy, our imagination, and what I can say for sure is that this shape of the soft tissue, this shape of the crest is not good for the molar. Sometimes, you know, a patient come to us just asking for one tooth. He's not asking for mucoderm, for emdogain, or for cerebone, yeah? But I have to give this patient, if this patient come to my office, I give a mirror in the hand and I show him, look, every tooth you have in your mouth, we have a base that is larger than your tooth. The crest is always larger than a tooth. In this case, if I put a tooth in this region, you don't have a base that is sufficiently wide. So we need to improve. Probably in this case, we have a good amount of keratinization. If you see, we can even collect some connective tissue from the palate. We can make a roll flap or something. I would do a CBCT in this case to detect if the bone is enough. If the bone is enough, I would just work with the soft tissue, taking from the palate directly. Probably, I think in this case, we have so much soft tissue that we don't need to graft with other biomaterials. But if bone is not enough vertically or horizontally or both, in both directions, we can graft with hard tissue and use the soft tissue of the patient. Second case, we have two failing roots. We have to remove these roots. We can see that is a maxillary case, so it's quite anterior because probably this region is canine, is lateral incisor and first premolar, these roots. So we are in the anterior region. And we have another problem in this case is that the neighbor teeth has restored. So what we can decide in this case is if it's better to take care about the bone without placing implants, and then at the moment of uncovering to place implants and probably together with connective tissue graft. In my opinion, as is anterior region, I would just regenerate bone without placing implants. Or another possibility is just to stabilize the blood clot without bone grafting and go back after 6 weeks, 8 weeks, placing implants, improving the hard tissue, and covering everything. At the moment of uncovering of the implant, we can make, if we need, a connective tissue graft, or if we have enough keratinization, a mucoderm grafting. That is probably the first choice in this case. Yeah.
Should we spend a couple of words here? Maybe as we discussed before, we could also have a general quick discussion about what to do when there's a tooth missing and we have resorption of the bone around it.
Yeah, in posterior area now we don't see very much, so we use more our imagination. In posterior mandible, very often we have a severe resorption, especially we have a lack of keratinized tissue. This is very, very common. We can also see the tongue that is invading the area of teeth. So probably we have to make a CBCT to detect how much bone we can have. And if we have enough bone for the implant, probably is not yet enough for a first molar in the mandible, because the first molar is the bigger tooth in the mouth. So even if we have enough bone for an implant, very often in this region I graft with bovine bone to increase the volume for a first molar that can be later good enough for chewing. Of course, the lack of keratinized tissue in this area is primarily solved with the connective tissue from the palate. Only if we have some millimeters of keratinized tissue, we can look for mucoderm as a good solution. So we have to measure many things: the bone, the kind of molar that we want to make, that normally is quite big, so we need an extra volume in bone, and sometimes a better situation of the soft tissue that is demanding we need a connective tissue. If we have a lack of keratinization, we can need just mucoderm if we have some sufficient keratinization.
Massimo, let me thank you, because it was a brilliant lecture, 3 hours non-stop, a lot of questions, a lot of interest. So I would like to thank you again. Thank you for joining us, and as usual, amazing presentation. So as usual, we'll talk again and soon see each other at some point. I would love to come to Florence at some point.
Thank you very much, Arturo. I also thank all the organization. Everything was fantastic in the organization. And what I would say, when I remember 2 years ago, I ran the New York Marathon, and every time I found people from Mexico, because there was plenty of Mexican people, fans all around in the streets, I always ran in front of them and say, "Viva Mexico!"
So they love you, I suppose.
Yeah, I was a false Mexican. I was a fake Mexican, because I need more support, because it was so tiny.
Okay.
So I was asking from Mexican people, because Japanese, I don't look so much Japanese. So
no.
I tried with the Mexican to be supported. So again, Viva Mexico. I hope to have the opportunity in the future to travel and to see you personally.
Then let's say Viva México. Gracias, Massimo.
Thank you.
Y para nosotros, para los participantes, vuelvo al español, simplemente para invitaros a quedarnos con nosotros mañana. Primero, quiero decir gracias por estar con nosotros, 3 horas con Massimo fantásticas. Y mañana empezamos otra vez en el mismo horario, a las 10. Vamos a tener otro guest international star de Italia, doctor Alfonso Caiazzo, juntos con Alejandro García y Ricardo Kern. Mañana va a ser un poco diferente, vamos a hablar claramente de regeneración, pero con, digamos, un aspecto un poco diferente, sobre todo en particular. El doctor Caiazzo va a hablar de preservación del alvéolo y nos va a dar una overview de los métodos, unos que hemos visto hoy también con Massimo. Y Alfonso Caiazzo va also a sugerir una nueva técnica y la vemos mañana. Entonces, otra vez, gracias por estar aquí y hasta mañana. Aquí tenemos la foto de Caiazzo. Bueno, gracias Massimo y gracias a Alfonso para lo de mañana y hasta mañana.
Your poison, you can follow me. You can run and hide, but you can never find a way. Like a crystal ball, I see everything. Got me on your mind, but mind your own, you never change. Inside it with you, inside it with you, inside it with you, but you don't follow through. Inside it with you, inside it with you, inside it with you, but you don't follow through. I've been through all the highs and lows, and lows, and I've seen it all from time ago. We make choices, gamble on a dream. Heard the stakes are high, but still you bet on everything. All those voices tell you anything. Baby, you gon' hurt yourself if you keep listening. Inside it with you, inside it with you, inside it with you, but you don't follow through. Inside it with you, inside it with you, inside it with you, but you don't follow through. I've been through all the highs and lows, and lows, and I've seen it all from time ago. Just hoping by now that you know, to see yourself out, time to go.
I see you walk by, baby girl, lost in the moment and it feels so good. Let's do a twist now, baby girl. I love the way you make me feel so good. Going down, going down, going down, that's the way we feel. Going down, running round, going down, that's the way we feel.
El sol me da esperanza, como tus ojos, pura pura pasión y amor. Yo lo siento y tú lo sientes. Energía, baby.
Baby girl, lost in the moment and it feels so good. Let's do a twist now, baby girl. I love the way you make me feel so good. Going down, coming round, going down, that's the way we feel. Going down, coming round.